What successes have you observed in treating patients with severe eosinophilic asthma with the IL-5 therapies to reduce asthma exacerbations?
The anti-IL-5 therapies have been shown to be very effective in improving asthma outcomes. All three currently available therapies that target interleukin-5, mepolizumab and reslizumab that target interleukin-5 itself, as well as benralizumab, which targets the IL-5 receptor, have been shown to reduce asthma exacerbations and have been shown to improve outcomes. Both mepolizumab and benralizumab have also been shown to reduce oral corticosteroid needs, and all three of these therapies have been shown to improve lung function. Clinically, in my practice, I've used a lot of all three of these therapies, and they're all equally effective in terms of improving outcomes in my patients. It's remarkable, actually, to see how effective these therapies are. And patients who've been plagued with asthma symptoms for years come back after just a few months and say how well they feel. So these therapies, relatively new in our armamentarium against asthma, are really, really effective, both from my perspective, but also from, and more importantly, from my patients' perspectives.
Can you share your insights on CRTH2 inhibitors currently in development? How will this change the treatment of patients with severe asthma?
The CRTH2 antagonists, including fevipiprant, are effective therapies that target the prostaglandin D2 receptor. They're novel therapies that have been shown to be effective in patients with eosinophilic asthma in phase 2 studies. It's going to be exciting to see the data that emerge from phase 3 studies that are currently in development. One of the novelties of this therapy compared to other newer biologic therapies is that the CRTH2 antagonists are oral therapies, and so will be a little bit easier to take and probably a little bit less expensive than other currently available biologic therapies. And thus, they may be prescribed before biologic therapies, given potential efficacy that we hope will be demonstrated in the phase 3 studies that are ongoing.
On top of what therapies are biologics prescribed? Can biologics for asthma be used in combination?
Biologics for asthma play an important role in targeting specific pathways, but they're generally recommended for use only in patients who are already on combinations of inhaled corticosteroid therapy with or without long-acting beta agonist therapies. And so these therapies are very effective in terms of add-on to those inhaled steroid LABA combinations with or without other therapies like tiotropium, and so should be generally used in that context. Whether or not they may be used in other patients who are either not on higher doses of inhaled steroids or long-acting beta agonists remains to be seen. I think further studies need to be done in that regard. To date, there have been no studies published examining use of biologics in combination, and we don't have any good safety data determining whether or not there may be potential interactions between different therapies, different biologic therapies, either of the same class or of different classes. Currently, we have agents that target interleukin-5 and IgE, and there are other biologics in development for asthma that are currently available for use in other indications like atopic dermatitis. One of those drugs is dupilumab, which is currently being evaluated by the FDA for asthma. While there have been no studies looking at these therapies in combination, there is anecdotal experience from several institutions suggesting that these therapies may be effective in combination to target different pathways. However, again, no studies have been done, and we don't have significant data, only a few isolated case reports.
With the phase 3 trial period complete for dupilumab, what role will this anti-IL-4 and 13 agent play in the armamentarium of biologics?
Dupilumab is a monoclonal antibody that targets the IL-4 alpha receptor and thus blocks activity of both interleukin-4 as well as interleukin-13. These cytokines are important players in type 2 asthma inflammation, and therefore it has a potential role to improve outcomes in patients with type 2 asthma. The current biomarkers that denote type 2 inflammation include exhaled nitric oxide, eosinophils in the blood or in the sputum, as well as IgE, an important biomarker of allergic asthma. Therefore, by blocking the IL-4 receptor alpha and thus blocking IL-4 and 13, one can have a significant impact in terms of affecting outcomes that are mediated by those cytokines. In particular, dupilumab has been shown to improve outcomes with dramatic improvements in exacerbations, significant improvements in lung function, as well as symptoms and quality of life. Because it's going to be prescribed every 2 weeks and likely to be prescribed for home use, that offers another advantage for patients with type 2 asthma inflammation. It's particularly effective in people who have high levels of eosinophils and nitric oxide. And so those patients in particular will benefit from use with dupilumab.
Should biologics be given even earlier in the treatment paradigm?
A question that often comes up is whether or not biologics should be given earlier in the asthma treatment paradigm, perhaps to prevent development of worsening asthma, of more severe disease. This is a very important question. Perhaps we could modulate asthma pathophysiology and prevent airway remodeling, or perhaps even reverse the course of asthma pathophysiology and prevent or cure asthma. This is an important question, and yet we don't have any answers as of now. Studies are ongoing looking at omalizumab, given earlier in childhood to prevent asthma down the road in susceptible patients. And studies are hopefully going to also be done with other biologics to see whether or not there may be a disease-modifying effect by giving these drugs earlier.
Are emerging agents such as tezepelumab, Phase 2b study complete, expected to make considerable contributions to the current number of biologics in their therapies for severe, uncontrolled asthma?
Tezepelumab is a monoclonal antibody that targets TSLP, thymostromol lymphopoietin. And that's a very important epithelial-derived cytokine that plays a role in asthma airway inflammation. It's proximal to type 2 inflammatory cytokines in the asthma pathogenesis pathways, and downstream affects IL-4, IL-5, and IL-13, as well as potentially non-type 2 inflammation. In early studies that were published in 2017, the Phase 2 data suggested a broad range of efficacy in both type 2 asthma as well as non-type 2 asthma, eosinophilic asthma as well as non-eosinophilic asthma, with significant reductions in exacerbations on the order of about 70%. Thus, we're looking forward to the Phase 3 data to emerge to evaluate whether or not this therapy is broadly effective. It's going to be exciting to see how this therapy fits into the asthma treatment paradigm and whether one should perhaps decide to target more proximally and have a broader effect across a broader group of patients versus using other therapies that are currently available, such as anti-IL-5 and anti-IL-4/13 blockers, to evaluate whether or not treating upstream may be the best way to treat asthma. These studies need to be done, and hopefully will be done down the road.
What effect do comorbidities such as obstructive sleep apnea have on the treatment of severe asthma?
Asthma comorbidities play a very important role in asthma pathogenesis, pathophysiology, and in asthma outcomes. Comorbidities such as obstructive sleep apnea, gastroesophageal reflux disease, chronic rhinonasal sinusitis, vocal cord dysfunction, and then even smoking all play a role in causing asthma symptoms and in mediating asthma airway inflammation. Therefore, it's important to address these comorbidities before attempting to target specific pathways, because the likelihood of success of treating other asthma pathways in the absence of addressing comorbidities may lead to less than optimal results. So what we do in our practice is we evaluate for obstructive sleep apnea and treat it. We evaluate for gastroesophageal reflux disease and treat it. We evaluate for for chronic rhinosinusitis and treat it. By treating all of these different comorbidities, as well as other ones, including vocal cord dysfunction, we can have a significant impact on asthma that may obviate the need for use of other therapies and have substantial benefits in terms of the patient's overall asthma management strategy.